Ladies and gentlemen, welcome to the first of our It's a Pain public engagement lecture. My name is Joanna Quinlan and I have been responsible for organising the lecture from the NHS side, along with my colleagues Nicola Massingham and also Dr. David Laird. I would like to just welcome, on behalf of the pain management team, those of you that are from the general public, and also those of you from Frammelgate School, because I know we did a satellite earlier in the day, and also our friends and family that have come to support us, healthcare professionals, our chief executive that's here, Sue Jakes, also those of you from Durham University, and last but not least, our patients. Where would we be without them? So basically I'm from a pain management team, and we are across 3 different sites. So we have a Durham-based team, a Bishop Auckland-based team, and a community-based team. And we are all part of Durham and Darlington NHS Foundation Trust, and proud to be so. Our service looks at chronic pain. So chronic pain is pain that a person has had for 3 months or more. It's pain that doesn't go away. It's bothersome. It gets in the way of your everyday life. And our service tries to look after every aspect of a person's life which is impacted by pain. And as a consequence, we have a very varied team. So we're made up of doctors, of nurses, of our medical secretaries, physiotherapists, psychologists, occupational therapists. As a team, we really wanted to be involved in this project because we're very passionate about providing the best possible service we can for people that have got chronic pain. And we really hope that this series will be an opportunity to link in better with our fellow healthcare professionals to provide a more efficient pathway of care for chronic pain patients, that we can make people in the public more aware of chronic pain so that people are more aware of what treatment there are out there. And also so we can back up the research that is going on in institutions like Durham University, which hopefully in the future will bring about some better treatments for our chronic pain patients. I'm obviously just one person of the pain management team, and there's quite a lot of other people from the team in the audience. So I'm just going to embarrass my colleagues for a moment and just ask you just to stand up for a second. Just so you can get an idea that we're quite a big team here, it's not just me. And we'll be around at the end. If anybody in the audience wants to come and speak to us, we'll be around at the end, and we've got a table of resources down the bottom here if you want to come and speak to us. We'd be delighted to speak to any of you. Thank you very much.
It's a great pleasure to introduce you to Dr. Mike Lee from the world-renowned, I think that's no understatement, Oxford Pain Imaging Group. And it's a great pleasure to have somebody like Mike who's an absolute expert in this area. So hopefully we're going to see some very nice images. I've built you up for this. So it's one of the few groups in the UK that really produce such high quality images, focusing actually on in the pain area. Okay, so you can really hopefully get a feel for what actually pain is by actually seeing things happen and within the system, okay? And the topic is how the brain is wired for pain. Very nice title. I think it sort of reminds me of a Cliff Richard song, I think. But anyway, I'm too old. The brain is a fundamental part of the system. I'm a neuroscientist, so the brain's my favourite organ. It's the most important organ in the universe, obviously. And you'll see that actually brain plays a fundamental role in pain transmission. And it's a real pleasure to welcome Mike to Durham for the first time, I think.
Thank you very much, Paul, and thank you very much for that kind introduction. And it's a real pleasure to be here, a real honor to be here to start off the series of of lectures, and I've titled the lecture "How the Brain is Wired for Pain," to try to give us all a sense of why pain comes about and why we can appreciate pain, why we are conscious of pain. I don't know everything there is to know about pain, but this is a scientific view. This is a view held by most medical doctors about pain, and let's see what you think about it. So have you ever touched a kettle, a really hot kettle, or a radiator that's just burning? And if you have, you feel pain almost immediately. But even before you feel pain, your arm will just withdraw on its own automatically. And all that will happen in less than a second. This withdrawal reflex is very important for your survival. It protects your body automatically. You don't have to be conscious about it. This happens whether you're asleep or awake. And for those of you who are anesthetists, you would see it happen even under a general anesthetic. It's that powerful and that robust. Over 100 years ago, this professor, Charles Sherrington, widely known as the father of modern human physiology, proposed a view that the skin, the external organ, has a sense of its own injuries as if it were conscious. And this sense extends also into your internal organs. Everything regulates itself automatically. This physiology is not only present in humans, but has evolved from very, very early times, even in very, very simple animals. Even invertebrates like snails and all that, they all have a nociceptive system. They all have a means of reflexively protecting themselves from a stimulus that can injure them, that can threaten their physical integrity. In humans, this is a lot more complicated. You can see the green line in the hand representing a nerve. And I'm going to call this nerve nociceptor, because that is exactly what it is. It's a noxious receptor. It senses very, very high intensity physical energy that can harm you, that can break your skin down, can cause you damage or even kill you. And this wire is connected right into the spinal cord, which you can see to the right of the picture. And through that, it gets joined to muscle, which then triggers the withdrawal response. So that's quite clear, and you might really appreciate this. How does the nociceptor do its job? Well, it's got very, very fine free nerve endings in one end. They penetrate right into the surface of the skin, right into what you call the epidermis, just on the top of the skin. This is a photograph of under a microscope that's been magnified over 200 times. And the nerve has been stained, the proteins on the nerve has been stained by a dye that's just specific to the nerve itself. And you can see it reaching right out into the surface. Now, guys, if you shave, you take the top of the skin off, and it always feels tender because you take a little bit of that nerve off as well. And nociceptors do a really important job, and they can do this job because they've got receptors, tiny proteins seen in a red circle. They're embedded in that. Now, each protein is very unique. It allows sensations of heat. It transduces heat energies, and they only do that at high temperatures. So it won't be sensitive to heat temperatures of 30 degrees, but you start firing at 45 degrees because 45 degrees is where your skin gets threatened. And evolutionarily, they know that. It's sensitive to acids as well, to pH, to harmful physical force, such as a needle through the skin, as well as to extreme cold temperatures, so anything less than 12 degrees. And at 0 degrees, it'll keep on firing, even though everything's shut down, but these receptors will keep going. And these receptors are very specific to nociceptors. And the reason why we're also interested in these receptors is because this is where drug companies or scientists can find new targets to block them one by one. Of course, it's extremely difficult because there are so many of them. Thank you, Paul. That's always worth trying. In fact, quite recently, if you've been up with the news, about a week ago, there's been a new drug from the venom of a black mamba that actually blocks the acid-sensing receptors. Of course, nociceptors allow us to appreciate chili peppers, curries, and all that, without which, what would life be like? The only thing that nociceptors cannot sense is X-rays. For some reason, we're not evolved to sense cosmic radiation, and this is one energy in the environment that can kill us without us knowing. So, we're not perfect. Now that's enough about the nociceptor, but it's very important to know that just because your nociceptor is active, just because a physical stimulus activates your nociceptor, that is not pain. And I'm just putting these slides out to show the extreme situations where nociceptive activity happens, where injury actually happens, but the experience might be something else. It is transformed because we're humans, because we are more than just nociceptors. I've got to do this slide all the time because this is the definition that we all hold by as scientists from the International Association for the Study of Pain that states quite clearly that pain is an unpleasant sensory and emotional experience. That means it's subjective, private consciousness. It's very unique. It changes moment to moment. The difference between physical pain and heartache and all that is that the person experiences always refers or links it to a physical stimulus, to an injury. Whether the injury actually happens or could potentially happen, it doesn't matter. It's linked. And the language that person would use to describe pain is always linked to the bodily part. It's a very distinct, we all know it, it's really hard to explain, but this definition really encapsulates it. And we should start from here. So consciousness, where does it come from? The brain. So this is Hippocrates, who states that men ought to know that from nothing else but thence the brain comes the consciousness of joys, delights, pains, and griefs. And that's why the brain is my favorite organ when it comes to pain, and which brings me to the lab in Oxford. So this is an MRI scanner. You can see a volunteer stuffed inside it. It's not a very big space, so if you're claustrophobic, it's probably not a great experience for you. It's also very noisy. The coils switch on and off. It rattles a lot. You'll be asked to wear earplugs in it. And because it's a huge magnet and it's on all the time, whether someone's in there or not, day and night, it's always on. So if you've got a pacemaker, metal in your body, well, we can't scan you, but there are other ways to look at your brain. But this is what we use in Oxford. Now, the magnet is quite a strong device. Now, to lift a car up, you need about 1.5 Tesla. This magnet is twice as powerful as that. We're going to do a small little experiment. Now, this is a hand. It's not my hand, but it's a hand of a volunteer. It's a nice hand. I think it's one of my lady colleagues here. And we get consent. We always get consent. So all the experiments are ethical. And of course, although we are looking at pain, but this is pain that is within tolerable limits. The person is always in control because he can say, well, stop. That's enough. So the experiments are not true to life pain because we can't always control true to life pain, but it can tell us something about how these nociceptors work and how the brain actually transforms these energies into a consciousness, really. Now, we have lots of different devices, but for effect, I'm going to show you a laser device. We like lasers in research, well, because we can do it, and it looks really cool. And I'm a geek, yes, it's true. But laser emits a radiant pulse of energy, and is capable of heating any surface up about over 1,000 degrees a second. So we only need to expose the laser for a very short time, maybe about 5 milliseconds, to get the skin heated up to about 47 degrees Celsius, and that's going to cause sharp, hot pain. But it won't damage the skin. That's the main thing. So this is not the whole laser. There's a fiber optic cable. Yes. Fiber optic cable dangling here, which leads to a real laser device. The first devices we used were actually cosmetic lasers used to remove spots. So that's a part-time job in our lab for some. Researchers are not very well paid. So I hope this clip works, and it should because I tried it. And just for effect, I'm going to do it again. It looks worse than it really is because the paper is black and absorbs all the laser energy, but it just shows you how precise we can actually place these with heat stimulus. And of course, if we do that to a volunteer and scan their brains, what we observe is this really, really widespread brain responses all over. At this stage, it's not really important to know exactly where they are, but to appreciate that it's very robust, it's very obvious, and very, very widespread. And why might this be? Well, because pain is not just a sensation, it's a very complex experience. When you've got pain, your brain's got to decide, where's that pain? How intense is it? How long did it last? It's got to code for all these characteristics. How much did it hurt? Was it frightening? Should I be worried about it? And then thinking about it, well, has this happened before? Will it happen again? Should I do something about it? So to code for all that requires distributed, widespread brain activity. So your brain's very, very active during the experience. But the brain is not a passive receiver of this. It's not just a loudspeaker. It can do something about it. Hence, mind over matter, great athletes, great soldiers, and even us, when we've got to do something in the service of something important, our brains can dampen down pain. We've got that capability. I like this picture because it's very calming, and it's of a Buddhist monk meditating. And I would love to scan his brain while he's doing that, but we don't really have a lot of them lying around in Oxford. So we settle for our psychology students. So this is another experiment. So we've got a laser stimulus again. We shoot it on the arm, on the hand, and we wait for 15 seconds for that pain to go away. And we ask, well, how painful? Please rate your pain from 0 to 10. Now, 0 is no pain, and 10, we always say intolerable. So we never hit 10, because if we hit 10, the experiment stops. It's always ethical. Now, this is the stage where I need a volunteer. Yes. I think you can stand up there. I'll sit up there, yeah, that's fine. And the task we get students to do to demonstrate this mind over method, this distraction thing, is a cognitive task. It requires a bit of mental skill. And what she's going to do is she's going to read not the words, but the color inside the words, and she's going to do it now.
Red, orange, green, brown, and pink.
Perfect. And again?
Green, blue, yellow, red, yellow.
And again?
Blue, yellow, red, orange, blue.
And all this time the laser is firing, and then we're going to do another. And now this.
Green, blue, red, yellow, red, blue, yellow, blue, white, green, orange, and then pink, and then after that's brown.
It's a lot harder. That's really good. I can never finish the list without giggling. But that's what you call a stroop interference task. So when you put the focus on the class, it's extremely demanding. Of course, you feel less pain, and it's reflected in the brain imaging as well. So the top is where the task was simpler, where the colors and the words match. And then the bottom bit's where pain is suppressed. So it actually happens in the brain that it can regulate in the service of something important. I'm not saying the Stroop task is important, but it's just an example. But you get the picture. Now, it's not only the brain. It turns out, and this is very, very recent, that the responses in the spinal cord are suppressed as well. So distraction isn't something in your head. It's actually doing something more peripherally, gating even the signals that are even ascending through the spinal cord. Now, what is unexpected is that some parts of the brainstem actually becomes more active rather than less active during distraction. And this part of the brainstem is called the periaqueductal gray. It's right there in the red. It's not a very good anatomical image, but it ought to be a little bit grayer, and it surrounds a canal, like an aqueduct. Hence, it's called the periaqueductal gray. And it turns out that the stronger the periaqueductal gray activates, the more pain relief you can have from distraction. So we're back to this slide. You have nociception, the firing of all those nerve fibers in the periphery. This signals feeding up through the spinal cord into the brainstem, into the brain, where activity that emerges for the consciousness of pain happens. But you also have a system that can put the brakes on pain, that can put the brakes on the signals coming out, right in the brainstem. And it's really useful. You can think of all sorts of everyday events that requires this system. It's all the time operating, keeping the balance, keeping in check, helping us deal with pain that's just manageable, that's useful, but not too much. But what happens when you get an injury? An injury happens, pain increases. It's normal. It's perfectly fine. You need to protect yourself. It's something we've all evolved to do. And part of this increased pain comes from inflammation. So when your skin is cut, the cells are damaged, they release chemicals. This forms an inflammatory soup, milling around tiny little nerve endings. These endings become very sensitive. The nociceptor over here fires off wildly, and you get more pain. It's very, very intuitive. What you might not realize is that the area surrounding the primary injury is also might become sensitive as well. Now, this is very, very interesting, because why might that be? Well, the nociceptor is not over here. It's normal. The skin's normal. It's not sitting in an inflammatory soup of chemicals. So if for this area to feel sensitive, something else is happening along this pain pathway, not the nociceptor. Would it be the spinal cord? Would it be the brainstem, or is it the brain? Now, again, my experiments are ethical. I can't go around getting people to sprain their ankles and then scan them. So I use chili peppers. This is an experimental model of injury and pain. It's great. So chili pepper, the active chemical is capsaicin. Now, capsaicin binds to a specialized receptor in nociceptor, only found in nociceptors, and with enough quantities, it stings like hell. So this is actually an insulin syringe. I promise you, the needle itself is very, very fine, very delicate. Now we put diabetics put insulin, and they can tell you doesn't hurt at all, but maybe they're used to it. But we put this just under the skin, like a mosquito bite almost, under the skin. And we put about 1/10 of a mil, so a tiny, tiny amount, just enough to create a tiny little bleb on the skin. And then we get the subjects to rate their pain. Obviously, the first few seconds, I don't really hear a number as usually, or something else like that. But when they get the sense of language back, I'll hear maybe 85, and we'll be timing them. So yes, it's quite intense, but the important thing to note that here is that, again, they consent. And the pain does settle down, and within about 5 minutes, it gets right down to 0. I've not met anyone that didn't respond that way. But what we're really interested in is not in this pain, but in the skin area that becomes sensitive when this pain is settled. So we wait half an hour. But before injecting capsaicin, we tested the area of skin, a normal area of skin for sensitivity, and we use a needle probe for it. The needle is not, well, it is sharp, but it's actually flat, so it's designed not to pierce the skin at all. So of course, if you increase the force of that needle, you get an increase in sharp pain. And then you do that capsaicin challenge, and you wait half an hour, and you find an area that's uninjured but sensitive, and then you repeat that needle testing again. And obviously, everything's just elevated. It just all becomes just that more sensitive. Now, if I scan the brain over here, looking for responses to the same force, but before and after capsaicin, then I'm going to get brain responses that are related to that increased pain sensation. So what you're going to see is really, really bright. Everything's just going to light up. But I'm not really interested in that. I'm interested in this. I'm interested in when a greater force in normal skin is compared to a lesser force on sensitized skin that gives the same amount of pain. So what the brain responses are going to tell me isn't about increased pain, but about the part of the brain being changed, being sensitized. And we did exactly that. And we found that, again, the brainstem is that key pivotal region that facilitates pain. And it's not the periaqueductal gray, it's actually an area just slightly lower down in the pons of the medulla, and we call this a reticular nuclei. So if I put this circuit together, you have very, very strong nociception. This is not a temporary injury. This is a very, very strong signal coming right up from the periphery, coming right up from the skin. And it travels all the way into the brain. But as it does that, it passes through the spinal cord, the brainstem, and it starts to change the way things are wired around there. And as a result of that change, the gain on pain increases. These facilitating circuits all become active. It's like the brainstem has become an amplifier almost. So the whole nervous system is not something that's passive. It's always changing in response to your input. Of course, this is a very useful thing to have when you really injure yourself and you need temporarily to increase the pain so everything is protective. And in my volunteers, within 3 to 4 hours, everything is back down to normal. But for some of us, after an injury, the pain doesn't always come back down to normal, does it? Even when healing has happened or has happened as best as it can. And this is the chronic pain state. This is exactly what Paul's talking about. Pain that has no biological purpose or meaning, that causes a great deal of suffering, for which there is no real easy or simple answers. Living with chronic pain is incredibly difficult. It's not just the experience of pain, it's everything around it, the thoughts. Is something wrong? Is it serious? Can I work? Can I take care of my kids? What do I tell my boss? How can I get to the shops? Well, my back scans are okay, but why is the pain still there? Have the doctors missed something out? Which treatment shall I go for? Why are people telling me different things? What if it fails again? And what if there is no cure? So this is the pain system in a healthy person, in a normal brain. All perfectly balanced, all poised, like yin and yang. When you add the fear, the worry, anxiety into that system, the whole thing becomes hypersensitive. A small little stimulus feeding through that amplified system is going to feel like a lot of pain. A tiny trickle is all that's needed. The difficulty is we still don't really understand what's keeping this system going, what's facilitating, what's feeding into it. And this is an area of enormous research. But back with coping with chronic pain, I mean, what do you think is needed to cope with chronic? Well, you've got to think positively in this psychology. You need willpower if you're going to exercise. It's not always easy. You need to be motivated, and lots of planning is involved as well. Medical appointments, arranging your life, making sure that you can enjoy the things you want to do. And all of that actually requires brain function as well, what they call the prefrontal cortex. The prefrontal cortex is this enormous part of the brain sitting right in front, and it's particularly huge in humans. Well, maybe dolphins might have a bigger prefrontal cortex, but for humans, we're doing pretty well. And it turns out that this prefrontal cortex is very well connected to the emotional part of your brain. The anterior cingulate cortex and the amygdala, you might have heard of with popular literature, areas that reflect the feeling of fear, anxiety. And these areas in turn project right down, surprise, surprise, through your brainstem into your spinal cord, regulating the signals that are coming out. So the prefrontal cortex is a really important area. And when this study was published over 6-7 years ago, we were all very surprised by it. And for a number of years now, researchers have been able to detect very subtle abnormalities in the prefrontal cortices of patients with chronic back pain, and also in other pain syndromes as well. Not just in terms of how thick the cortex is, but also in terms of its neurochemistry. The problem with these studies, they are what they call cross-sectional studies. They take a snapshot. So there's no way of telling whether these changes were there before the pain started or these changes are there as a result of pain. And we are still trying to work out what do these changes really mean in terms of coping with pain, in terms of living with pain. And over the years, I think I should say this, that there are studies coming out now that say that these changes are actually reversible and they're not always fixed. So the brain is actually quite plastic. I'm going to conclude the talk with this study that's just hot off the press, just published a few months ago. In this study, the researchers took a group of patients with back pain, but only a month, just a sprain, nothing wrong on the scans that they can detect, nothing that any doctor was concerned about, and they followed these patients up for a year. And of course, some would recover, and others, unfortunately, would have pain that persists. And what the researchers wanted to find out, what we want to find out is, well, is there anything in the brain that would predict the development of pain, the persistence of pain? And it was really, perhaps comes as no surprise that this prefrontal cortex has emerged as quite an important area. So, in very simple terms, how the prefrontal cortex connects with your emotional brain thus predicts whether that patient is going to then end up in trouble later. We still don't understand how sensitive this test is, and no doubt there'll be a lot of work. Because think of what we could do if we could predict, we could perhaps intervene. I mean, what might help cognitive function? Would psychology help it? Are there drugs that can improve it? We don't know, but there's a lot of possibility there. Of course, when I look at prefrontal function, I sometimes wonder, in terms of psychology, which requires a lot of work, whether do all of us have that capacity to do that, and how can we improve that capacity? Are there cognitive enhancers that can be used? A lot of drugs in pain medicine tend to cause sleepiness, damp us down, but are there other drugs? It's something in the future to think about. So, in summary, I want to say that nociception is not enough for pain. Something else must happen, that something happens in the brain. And your central nervous system, the brainstem, the spinal cord, has control over nociception to give the appropriate pain for the situation, depending on what you want to do, whether you're an athlete, a soldier, a student studying. But sometimes things go wrong, and this is where we're not really quite sure, and this is where a lot of work is being done to see if we can get a better diagnosis, a better handle on the pain that people suffer. Living with chronic pain is extremely difficult, and how the brain functions may determine how well the patient copes with pain. And that's why interventions like psychology, pain management are just so critical. A multidisciplinary approach to pain management, which my colleague will no doubt tell you more about. Well, thank you very much for your time.
Thank you very much. Now we have an opportunity for questions. We've heard a very clear and right up to date exegesis of where the current level of neuroscience is with regards to chronic pain. But if you have questions, we'd be pleased to take some time and discuss them. Thank you.
Thank you very much. It's very interesting. It's not a pain-related question, but I wonder if I'm present sensation like feeling cold also helps like influenced by psychology. If I'm feeling cold, I'm feeling cold more.
I think if there is an unpleasant component to an experience, yes, of course, psychology would play an influence as well. I mean, pain is often thought of as a psychological state. Although I've mentioned that pain is often referred to something physical, but unpleasant sensations, heartache, and all that, they all sort of feed into this pain network as well. So yes, most certainly, that's the case.
Thank you.
Do you know anything about the blood pressure of these patients? Because a lot of the areas you see are connected to the neural control of the cardiovascular system. So are there changes in their ability to regulate their blood pressure, which match what's going on with the pain response?
In terms of the acute pain response, we've always tried to control for that. So, it sits very, very closely to cardiorespiratory centers, and of course, it is actually what forms part of the reflex as well, to a noxious stimulus. And that's actually very relevant in terms of acute pain. The chronic pain is a very different entity because in many cases they don't have that pressor response and all that. And we certainly haven't really been able to map these responses, these heartbeat-related responses in patients. But we do try to control it for them.
Thank you.
Can everybody hear at the back? Not really. No? Okay, so if you don't mind, if people elevate their voices a bit.
Sorry. Yeah. So you described how if you have pain, you start to become more sensitive around that area. but you also described battle soldiers who might not feel pain. And my question is, if that pain is suppressed in that kind of way, does the skin or other parts still become sensitive? If actually that's being suppressed during that period?
It's a difficult one. I would imagine that if the injury is very acute and before inflammation has time to really set in, before cessation has taken place and in the heat of the moment, they might not feel it. But I would imagine that it's very, very difficult to, in a very sustained way, engage descending facilitation. And eventually that is going to break through when there is the time and space for that. If nothing else, the amount of pain that the brain allows you to feel is going to be appropriate to the situation, to the social demand, to the environmental demand. And once there is no demand on the battlefield, that's when it's going to hurt. It might hurt a lot less because the soldier might be due for an honorable discharge versus a civilian, in a car accident. But there is where contacts play such a big role.
But thinking does play a large part. In some of the early studies, the difference between a patient who had rheumatoid arthritis and they could see the damage caused in their joints, the amount of brain that lit up was much less than somebody who had a different pain state, scoring it on the same pain score, but for whom there was no explanation of their pain. Is this something which you're familiar with? Or?
Not directly, but certainly the idea of perceived controllability of pain is quite an important factor in deciding how unpleasant that pain is going to be. There's probably nothing worse to a human being who is so highly evolved to lose control of his environment. In fact, everything we do is really about predicting how the weather is going to be like. Can I do this? Or worries, all that, and not being able to control or understand your pain or where it's coming from is a great source of distress. And I think that's why education is so important in pain management.
Would you like to expand just a little on sometimes things go wrong?
That's a tricky bit when things go wrong. The truth is, we don't have the full picture, and when it comes to stuff like that, we try to see if we can find parallels in animal models. Now, I know not everyone here is in favor of animal models, however ethically treated in terms of studying pain. But it happens, and we learn from that. So a nerve injury in a rat, for example, is meant to simulate a nerve injury in a human being. And of course, in humans, that's something gone really wrong that never really quite recovers. But surprisingly, what we've found in rats, and we can't really keep them in pain for too long, they are sacrificed because it's the ethical thing to do. But the first thing to say is that it is actually quite difficult to induce a pain state in a rat. It's tremendously difficult. The species almost has to be bred to be genetically susceptible to pain. And even when they develop pain behavior, it doesn't seem to last for very long. Many of them spontaneously recover in terms of the behavior, even though there is a nerve injury. And this is something that we're really, really curious about and really trying to get into understanding. And if I could do a study where we look for patients who have recovered from pain, that would be a great one to really find it. So actually looking into people with pain is interesting, but looking at those who are able to cope, who recover, is actually a very interesting question as well, but we haven't been able to do that sort of studies, but we do really want to get into it to understand the differences in how things go wrong.
Thank you.
My terminology may not be right, but can you tell acute pain from chronic pain in the leg? I have terrible pain in my leg. It feels sometimes as if somebody hit it really hard with a lump of wood. But if I went along with somebody else who had actually been hit very hard on the thigh with a lump of wood, could you tell by looking at the brains which was which?
I got to say I'm not sure. Yeah. The idea of between acute and chronic has always been one of timing. So acute means, well, anything less than 2 months. and chronic means it's lasted longer. But within chronic pain, there are times where it's more painful acutely, and then it settles down. This intermittent type pain.
Well, what I was meaning is something that had an obvious cause.
Yeah.
Something had actually been hit with
Right.
an object across the leg.
So if you're talking about pain that's coming up as a result of an injury, there's a lot of feeding up. Whether we can tell that difference from a pain that's contributed by more central cause. Is that what you're referring to, sir?
Yeah.
Okay.
Does it look different to the red?
I can answer that question partly. So one of the things that we try to understand is how does physical pain differ from pain that's more emotional or psychological? And this is a really tricky one. I'm not saying in any way, sir, that your pain is related to psychological cause, but it allowed us to do experiments where we compare patients or healthy volunteers really with laser-induced pain or heat pain, but these volunteers were also very susceptible to hypnotic suggestion. So through hypnosis, they can actually experience pain. And then we compared the brain images because what we wanted to do is to see where is the difference where the pain is physically induced versus psychically induced. Is there a marker? Because if we can find a marker for physically induced pain that's coming right up from the knee, then the treatment might differ. We know you might decide surgery is a good answer because it's all coming from here. But if it's more central in the nervous system, then chopping off or changing that knee is not going to do any difference. And the short answer is yes, there are differences, and the difference lies in this area called the posterior insula. But the difference is very subtle, and there's a big variation, so we can't really use it as a diagnostic test. So if it sits somewhere like that, the range, so if you're in this gray range, we're not really sure, but extremes, yes, perhaps we can say with some certainty or some degree of certainty, perhaps, that the pain is coming from. But this is, again, a very interesting piece of work, and a very good question as well. Yes?
Just in connection with that, really, another difficult question, and it's on the masking of pain. And I'm thinking, for example, an elderly patient who has coexisting problems, perhaps spinal problems, and you could have somebody with osteoporosis and a tumour in the spine, and they've got pain from both, but the pain is masked and muddled. And can you comment on that?
I think that's every doctor's nightmare, to miss a diagnosis. And the only thing I would say is follow up and follow up again, because that's the only way you're going to tell. Time would tell, and it's just important to just keep looking at the pain again. Always take the pain at face value and keep an open mind, not wanting to alarm the patient, but also not wanting to miss a diagnosis. And it's a really tricky one. I'm sure my team would appreciate it.
I think listening to the patient, if the patient says this has changed or this is different, is an extremely sensitive and sometimes quite a specific indicator. As doctors, I think we must continually listen and actively listen to the patient who knows their body, better than we know them. It's just in the same way we may know the drug and what it should do, but the patient knows how that drug interacts with them.
In the case of an elderly person, though, they perhaps haven't got the assertiveness skills,
yes,
or the communication, to get it over. And it's a really big problem.
And we have been helped. If we look at what imaging we have now compared to, say, 20 years ago, that has made a huge impact. But just in the same way that nociception is not pain, the number of times that we do imaging on patients looking to see something on their left side, and the image X-ray shows up something on the right side, but nothing on the left, and then where do we go with that? So it's more than just the X-ray.
I'm quite interested in how the subjects were chosen for the experiment. Is the sort of pain influence? I really ran away from that before. Who volunteered to have that amount of pain influence on them?
So some of the subjects were actually neuroscience students. Others were actually members of the public. It's very variable. But you're right, there is always a bias when you're looking at doing experiments in Oxford. I was trying to do an experiment on cannabis and trying to find naive subjects, and it was really hard. So it really does depend. So how generalized, experiments like this? I'll be honest. Will it generalize to another culture, to another place?
Does a public school education make a difference?
I extend a question on that. So you're dealing with patients in our centre.
Yeah.
Then the no pain, no gain group seems to respond quite well.
All right.
I'm interested in that phrase in itself, it's like, whole no pain, no gain. And then the whole other group are really hypersensitive and can't be touched. I'm just wondering whether the brain lights up in a different way.
Well, it will probably do, yes, if you're catastrophized. There are studies that will demonstrate that quite clearly, yes.
And then,
hello, thank you very much, it's very interesting. On behalf of all the psychologists in the room, thank you for reaffirming our role in the team. Given what you're saying about the experience of pain being mediated through the prefrontal cortex and the role of thinking, is it possible in theory that helping someone become less anxious, less fearful, could be as powerful a change in their pain experience as, say, medication?
I'm going to say yes. It's a tricky one because, in terms of the strongest medication we have for pain, let's say opioids, although there are receptors for opioids everywhere, but in humans, the opioids act mainly in the central nervous system, and that we know from anecdotal studies of methyl naltrexone. So this methyl naltrexone is actually a subcutaneous injection that's given to some patients with opioid-induced constipation. And the good thing about this drug is that it stays in the periphery, it doesn't enter the brain. And of course, when this drug was first being introduced, they were worried, well, if opioids are actually working in the periphery and in the brain, then this drug's going to change everything. But no, this drug reverses constipation without changing opioid-induced pain relief. So, but there are opioids that are exogenous, the ones that we administer, and there are also endogenous opioids as well. And the endogenous ones might be what psychologists tap into, really. And there are no side effects because it's specific, but it's hard work. Yeah, challenging.
Yeah, sort of relating to the question about how people chose the study. Is there any evidence for correlations with different stages in life for how the pain is dealt with in the body? So, does the pain system develop sort of from very young in the same way? Does the pain system change with age? Or
It certainly does. I mean, in neonates is wired differently. They've got more unmyelinated fibers. And I can't tell you very much more beyond that, but we've got Rebecca Slater, Merritt Fitzgerald, who's doing a lot of work in the neonates and looking at how the neonatal system actually is transformed with time. And in terms of the elderly, there's suggestion that dampening system just becomes slightly less effective. But again, it's evidence and not proof. But in terms of clinical experience, that seems to bear itself up quite well.
But I guess there's a lot of bias by as you get older, you become better at dealing with the pain because you've had many more experience.
That's what I like to get at when I'm older, yes.
but I think one of the things that happens clinically is that as doctors, we see patients who may have been in pain for quite a while, but something has happened, whether related to the pain or some other crisis in life that has tipped them into an unstable, uncoping state. And I think that can be as big a factor, and it's how we help people get back on their perch again. But I think there has been some work with neonates and looking at them if they've been in intensive care units as babies with lots of blood sampling and their impact on the nervous system and the responses 10, 15 years later. There's some recent publications on that shows that they are quantitatively different from children who are full term. So brain really is plastic, as in nothing made in Hong Kong, but plastic in terms of making specific changes. 1 and 2.
If you have an injury and you've had it untreated for over a long period of time, are you more susceptible to have chronic pain?
So can you repeat that question again? I'm buying time here.
A long-term injury that goes a long time without being treated, are you more susceptible to having chronic pain after it has been treated?
So if you've been stressed before by pain and that gets treated and that pain resolves, does that mean that somehow you are primed for pain in the future?
No, it's
It's untreated.
like in the same area.
I think if the pain has continued before there's any treatment initiated, is that worse than if treatment is initiated as soon after the injury as possible?
I don't know of any clear but preemptive analgesic.
Oh, yeah.
Yeah, do you want to say that?
No, you go ahead. This sounds fairly obvious, and so obvious that anaesthetists spent a lot of time going, let's get every known analgesic into the body before a surgeon commits trauma to a patient, because that's what surgery is, controlled trauma in a humane way, thanks to anaesthetists. And a wide range of drugs were used to try to dampen down all those red circuits. And the results? Virtually no difference 3 months, 6 months down the line with patients who had had the standard type of treatment. So it doesn't answer your question in terms of what happens if you've had pain and a lack of treatment for a long time, but we know that early treatment is not as hopeful as we had wished. Would that be a fair summary of where we're at?
I think so. I mean, preemptive analgesia hasn't lived up to its original promise, but I think it's really very difficult to always completely block the periphery from sensitizing the nervous system. I think in order to not let injury get to your core, you would have to literally numb this leg completely, but then you would lose every other function. So I think as an idea, it really works. In animals, it works really well because we can do that. But in reality, it's some difficulty translating that. But I think pain should be treated as soon as possible. It doesn't matter whether that pain is going to become chronic or not, mainly because it's the humane thing to do. You cannot always treat pain, but you should always treat the suffering and distress.
I had another question.
Can you explain chronic regional pain syndrome where there's no initial trauma or injury?
No initial trauma. Do you want to take that? So chronic regional pain syndrome is as it says on the label, at least not chronic, it's complex, isn't it?
Complex.
Yeah. So it's complex regional pain, so it's complicated. It's regional, so it's going to be in one part of the body, and it's a pain syndrome. I can't remember who first described it, but there are two types. One that's associated with a nerve damage, and the other is associated with an injury, but not a nerve. There has always been an initiating injury in terms of its definition. But the injury is so minor, like a sprain, for example, in the hand.
My patient doesn't report any injury.
Right. Would you then define it as chronic regional pain syndrome? It's complex. It's very much localized. It might be that the injury is so minor that it doesn't really bear remembering. That's not unusual, I would think. But yeah, the thing is attributing the cause of the initiating injuries is not always easy in patients with long-term pain.
And a lot of the inflammatory mechanisms and the pain mechanisms are based on a cascade type system where you make a small change at the start which gets amplified at every level and then gets hopefully turned off, because that's the normal pattern, so that we don't feel our shoes on our feet after we've put them on. We don't feel after we've sat down, because we turn a lot of these signals off, or at least keep them unconscious. But for some reason, it's not been turned off, and that persists. And then the changes to that pain happen as if the injury had occurred or was as large.
And these changes can be seen on imaging?
Yes, X-rays can show, but some are, and it is more than just the disuse of, I put my arm in a plaster and I see some bone thinning after 3 months. These changes can occur within weeks with a number of changes to the bone, to vascular system, to the nerve tissue itself. It's a complex and integrated system, and just a small perturbation in it can make a massive change. I think the amazing thing is that for most of us, we cope well with pain, and most pain gets switched off appropriately. The system works well for most of the time. Even for people who are in chronic pain, you still will bang your foot, you will still get a headache, and the system will still turn that off. It may not turn your chronic pain problem off, but it may turn some of the other day-to-day pains off. So that system is still working. And I find that fascinating. But I wish we could access it more.
Certainly this complex regional pain syndrome is all that peripheral change, but there's also a very interesting neurological finding in these patients is that they have what they call neglect-like symptoms, in a sense that they rather not, the arm would be really painful, but they would just ignore it. It's almost as if they want it cut off. They're so detached from it. And as a result of this neglect, they have actually spatial abnormalities in the brain. So the representation of that arm in the brain is actually very, very small. And that representation changed actually with therapy. So I've got to be really careful here. But Lorimer Moseley, who is very well known for the graded imagery therapy, would say that the way to treat chronic complex regional pain syndrome with neglect is to get them to touch it, feel it, move it, love it. They've got to start ownership again, and really spatial training to desensitize almost the fear of moving and recognizing the arm. So I'm not really sure any of that is applicable to your patient, but if it is, I hope it helps.
Thank you.
1, 2.
Sorry to be disruptive, but really have to go and to disturb you.
Thank you.
Thank you very much.
Okay. 1 and then 2.
Thanks, enjoyed your talk. I was just wondering, excuse me, what are you up to next? Where are you going with your research, and why do you think that direction that you're going in now is useful for the field? Where is it going to take us to?
Shall I give you my grant ideas?
just a hint.
Okay. So my background, I'm an anaesthetist, and so in terms of pain management, what I do best is to really look at pharmacology. And I've always been really interested in the failure of pharmaceuticals to come up with anything new. So we've had 20 years worth of research. You saw that receptors I put up. There's only been one new drug that's come up from basic science research, it's ziklonatide. And how many of you have heard of it? Well, wow, I'm very impressed. But that's the state of play. They don't really translate very. So all animal studies are very, very sensitive assay. Everything that we humans use and work will work in animals as well. But the reverse is not true. And so it seems that we've got to bring a lot of these compounds to test in, well, human subjects, but in a quantifiable way. And that's where brain imaging comes in, because brain imaging allows us to quantify very, very similar, well, at least as similar as we can get it, neural circuits in both and across species. So it's almost a common metric, because you can't get animals to complete a pain questionnaire any more than you can put a human on a hot plate. So that's the sort of research that I'm really interested in. And at the moment, we're looking very much at opioids and what it does, what it can't do, how we can actually improve it. And cannabis is another favorite of mine. I don't use it, but it's interesting drug, yes.
Thank you very much. And if I can make this the last question, but there will be opportunity to talk and ask further questions informally at the front at the end. Thank you.
Well, I hope the question will not be answered, but I wonder whether you told us there's aging differences. I wonder, are there gender differences in perception?
You should speak to my colleague, Katie Vincent, who is an obstetrician, really interested in pain. And she spent 3 years of her PhD chasing girls through menstrual cycles. And the short answer is yes, and it is hormonal, it's related to hormones. That's the short answer. But come see me after this.
Okay. Well, first of all, may I, on your behalf, thank Dr. Lee for coming up and giving us such an excellent lecture to start off our series. So thank you very much. And I think he has illustrated that modern technology, clinical practice can actually advance and help us to move forward. But as Paul was saying right at the start, your involvement in this project that we are embarking on, in how do we find out more about pain, how do we disperse the knowledge that is there, how do we explore the different facets of it in our community to the advantage of the people who we live with, who we work with, whether in the academic setting, in the clinical setting, or because you're a carer or a sufferer. These are things that we want to engage you with. And your views are important, and your vitality, your interest, your knowledge, your future and potential that we wish to harness and link this in with this for the benefit of County Durham. So, thank you very much for coming. If you are a professional and you need evidence of continued professional development, we're happy to sign certificates for you. If you want to leave contact details so we can keep in touch, and if you want to actively get engaged and give suggestions for further workshops and lectures, we would be keen to hear from you. So again, very many thanks for coming. Thank you very much.